Hello, my name is Monica Mahoney. I am a clinical pharmacy specialist at Beth Israel Deaconess Medical Center. I work in the outpatient infectious diseases clinic and also with our OPAT program. In this presentation, I will review the data for the use of zinc, specifically as it applies to SARS-CoV-2 or COVID-19 as part of the Society of ID Pharmacists COVID-19 resources. Let's take it back to chemistry, way back. Think to the periodic table. We are reminded that zinc is a mineral, and it's considered a trace element. Zinc is involved in many different functions and components of cellular metabolism. Zinc is required for the catalytic activity of about 100 different enzymes in the body. It is also closely related to immune function, protein synthesis, wound healing, DNA synthesis, and cell division. Clearly, without zinc, life as we know it would not be possible. The recommended daily intake of elemental zinc differs based on sex and age of the patient. For adults, the recommended intake is 11 milligrams per day for males and 8 milligrams per day for females. Zinc is relatively safe with high upper intake levels. Both male and female adults can tolerate up to 40 milligrams of zinc daily before experiencing adverse effects. After several days or weeks of higher zinc intake, patients can report mild adverse effects such as nausea, vomiting, diarrhea, decreased appetite, abdominal cramping, and headaches. Repeat ingestion of 150 to 450 milligrams of zinc per day can result in the more chronic or severe effects of decreased copper levels, altered iron function, and decreased immune function. Note that these values pertain to the amount of elemental zinc. There are no serum zinc levels to check. Both zinc deficiency and zinc overdoses are determined by clinical findings. Several formulations of zinc are available, with the most common including gluconate, sulfate, and acetate. They all differ in the amount of elemental zinc that they provide. Shown in the green and white boxes are the different salt equivalents to deliver 1 milligram of elemental zinc. Over-the-counter zinc lozenges are usually the gluconate salt, and on average, one lozenge contains 13.3 milligrams of elemental zinc. A 220 milligram zinc sulfate tablet or capsule, another common formulation, provides 50 milligrams of elemental zinc. Zinc is closely related to immune function. This study was conducted based on observations that elderly patients are often zinc deficient and that they can experience many bouts of nonspecific infections. This study was a 12-month placebo-controlled study investigating whether supplementing zinc could restore immune function in the elderly. 49 patients, aged 55 or older, were enrolled to receive zinc or placebo. 24 patients received zinc gluconate and 25 patients received placebo. The average age was 65 years. In the patients receiving zinc, they received 15 milligrams orally in the morning and 30 milligrams orally in the evening of elemental zinc. The study was conducted in an adult daycare center, but for independent adults. The nurse practitioner was assigned to evaluate and categorize any reported infections. Overall, infection rates decreased in the zinc group. The infection rate was 29% in the zinc group versus 88% in the placebo group, with a p-value of less than 0.001. The most common types of infections reported were cold, upper respiratory, fever, or flu. There was no difference among infection types between the groups. The authors concluded that zinc supplementation administered to an elderly population resulted in a significant decrease in the incidence of infection. A cold was the most common reported infection in the previous study. Whether zinc can be used to treat the common cold has been investigated in a number of other studies. A Cochrane review was scheduled to be completed and published in 2017 on this very topic. However, because the timeline was not maintained, the Cochrane review was abandoned. The lead author went on to publish a meta-analysis instead. In this meta-analysis, zinc lozenges of at least 75 milligrams of elemental zinc per day were evaluated for the ability to treat cold symptoms. 7 studies were included, with 3 using zinc acetate and 4 using zinc gluconate. Overall, the use of zinc at the start of cold symptoms reduced the duration of symptoms by 33%. It is important to note that the zinc lozenges were to remain in the oral cavity and allowed to dissolve, not chewed or swallowed prematurely. The author performed a number of sub-analyses as well. When differentiating by zinc salt, it appeared that zinc acetate and zinc gluconate lozenges performed the same. Salt did not matter. When differentiating by the total daily dose, similar results were seen with a total daily dose of less than and greater than 100 milligrams. And lastly, when differentiating by amount of zinc per lozenge, or by frequency of zinc administration per day, these results were too heterogeneous to draw any conclusions. Colds are caused by a multitude of viruses. While rhinovirus is the most common, coronaviruses are also involved. Since zinc lozenges worked on colds, can zinc also work on coronavirus? In 2010, in vitro studies were performed with zinc and the original SARS virus, SARS-CoV. Using Vero E6 cells infected with SARS-CoV, the authors investigated the role of zinc in pyrithione on virus replication. Pyrithione is a zinc ionophore. It facilitates zinc transportation intracellularly, therefore increasing intracellular zinc concentrations. The authors found that as the intracellular zinc concentrations increased, by increasing pyrithione, SARS-CoV replication was inhibited. The RNA synthesis of SARS-CoV is catalyzed by an RNA-dependent RNA polymerase called RDRP. The zinc inhibited RDRP elongation and decreased template binding. The end result was inhibition of SARS-CoV synthesis. Then, completely unrelated to SARS-CoV, as his 2014 title divulges, an in vitro study found that chloroquine was also a zinc ionophore. Chloroquine enhanced intracellular zinc uptake in a concentration-dependent manner. Additionally, the zinc enhanced the cytotoxic activity of chloroquine. There appeared to be a synergistic relationship. For additional information regarding the data on the use of chloroquine and hydroxychloroquine in SARS-CoV-2, please refer to the other SIDP reviews. There are several proposed manners in how zinc can interact with SARS-CoV-2. However, most are theoretical and are lacking evidence. First, zinc may improve pulmonary cilia morphology and increase ciliary beat frequency, improving mucociliary clearance and removal of particles. Second, zinc can inhibit RDRP and block SARS-CoV synthesis, as we previously discussed. Third, zinc may have a role in upregulation of interferon alpha production. Fourth, zinc may have anti-inflammatory activity through a variety of mechanisms. Fifth, if the patient is co-infected with streptococcal pneumoniae, zinc may modulate bacterial homeostasis. And lastly, risk factors for increased COVID-19 mortality seem to overlap with risk factors for zinc deficiency. Zinc supplementation may be beneficial in modulating some of these risk factors. Again, many of these pathways are theoretical, and there is limited to no evidence supporting these claims. Recently, a preprint has been made available investigating whether the addition of zinc sulfate to azithromycin and hydroxychloroquine had any impact on hospitalized patients diagnosed with COVID-19. Caution that this is a preprint and has yet to go through the peer review process. The authors retrospectively looked at patients admitted with a COVID-19 diagnosis between March 2nd and April 5th. Around March 25th, the 4 hospitals incorporated zinc into their treatment recommendations. Therefore, they compared 521 patients who received hydroxychloroquine and azithromycin to 411 patients who received hydroxychloroquine, azithromycin, and zinc. The patients were well matched. There were no differences in demographics or inflammatory markers. In the rare parameters where there was a statistical difference, there appeared to be no clinical difference. Overall, the authors appeared to have obtained comparable groups. So, what did their results show? In the univariate analysis, the addition of zinc to hydroxychloroquine and azithromycin did not affect the hospital length of stay, mechanical ventilation duration, average or maximum oxygen flow rate, or average or maximum FiO2. On bivariate logistic regression analysis, however, there was a decrease in mortality or transition to hospice, a decrease in need for ICU care, and a decrease in invasive ventilation. However, when further investigating the decrease in death or transition to hospice care, it was discovered that this was mainly driven by a non-ICU population, meaning that if the patients were sick enough to require ICU care, the addition of zinc did not impact mortality or transition to hospice. Additionally, the authors adjusted for time, since zinc was not added until several weeks into their pandemic surge, and knowledge of the disease could have impacted care. Even with this time adjustment, the authors found that patients who received zinc showed decreased rates of mortality, again driven by the non-ICU population. The authors commented on a number of limitations, the biggest being that this was a retrospective observational study. But they concluded that the addition of zinc to hydroxychloroquine and azithromycin decreased mortality in a non-ICU population. They hypothesized that zinc could potentially prevent the progression to more severe disease. Once a robust inflammatory response occurs, such as a cytokine storm, the addition of zinc may no longer prove to be beneficial. To their credit, the authors concluded that this study alone should not be the basis for clinical practice, but rather would support randomized controlled trials. Luckily, there are 6 trials currently listed on clinicaltrials.gov investigating the use of zinc in SARS-CoV-2. 4 trials are looking at zinc for the treatment of COVID-19, and 2 trials are looking at zinc for prophylaxis. The trials are in various stages of recruitment, so please refer to the website for the most updated status. Let's take a closer look at each of these trials. The first trial is a randomized open-label treatment trial in outpatients diagnosed with COVID-19. Patients will be randomized to one of 2 triple therapy groups. The first group will receive hydroxychloroquine, azithromycin, and zinc sulfate for 5 days. The other group will receive hydroxychloroquine, doxycycline, and zinc sulfate for 5 days. The doses are provided for you, and note that the zinc sulfate dose is equivalent to 50 milligrams of elemental zinc per day. The primary outcome will be time to symptom resolution. The second study is the HAS-DPAC study, an open-label, single-arm quintuple treatment trial consisting of hydroxychloroquine, azithromycin, vitamin C, vitamin D, and zinc. Neither the doses, zinc salt, nor durations of treatment are known at this time. The primary outcome will be successful treatment at 24 weeks. The definition of successful treatment was not provided on the trial site. The third study, the Zinc D3 COVICI trial, is a randomized open-label treatment trial of inpatients aged 60 years or older. The intervention arm will include zinc gluconate twice daily and vitamin D3 once daily for 2 months compared to standard of care alone. The primary outcome is survival rate in asymptomatic patients. A secondary outcome will include survival in symptomatic patients and overall survival. The last treatment study is a smartly titled COVID A to Z study, which is an open-label 4-arm treatment trial. Arm 1 is zinc gluconate 50 mg monotherapy. Arm 2 is zinc gluconate 50 mg plus vitamin C, or ascorbic acid. Arm 3 is vitamin C monotherapy, and Arm 4 is a standard of care. Treatment will continue for 10 days, and the primary outcome is time to symptom resolution. For prophylaxis, the HELP COVID-19 trial is an open-label, single-arm prophylaxis study in healthcare workers who are at high risk for COVID-19. High risk is loosely defined as any frontline healthcare worker. Patients will receive a cocktail of hydroxychloroquine, vitamin C, vitamin D, and zinc. The doses, zinc salt, and duration are unknown. The primary outcome is prevention of COVID-19 at week 24 by keeping a daily symptom tracker diary. The second study is described as a case control prophylaxis study of healthcare workers. The only listed study arm is hydroxychloroquine once every 3 weeks, plus daily vitamin C and daily zinc. Again, the doses of vitamin C and zinc and the zinc salt are unknown. The primary outcome will be protection against COVID-19 at 4 months. Several of these studies incorporated the use of vitamin C. Please refer to the SIDP website for additional videos of the use of vitamin C in SARS-CoV-2. In terms of zinc dosing and toxicity, these were previously discussed. In the pending clinical trials, with zinc doses provided, they were above the tolerable upper intake levels, but if only taken for the 5 to 10 days listed, side effects should be minimal and tolerable. Fortunately, there are a limited number of drug interactions with zinc. Zinc is a polyvalent cation, therefore care must be taken with oral co-administration. Some of the larger classes of medications that must be spaced out from cations include some antiretrovirals, in particular bictegravir, dolutegravir, elvitegravir, and raltegravir, and certain antibiotics such as quinolones and tetracyclines. Please refer to the specific drug monographs to determine how many hours in between doses are required for optimal drug absorption. Additionally, certain diuretics, such as chlorthalidone and hydrochlorothiazide, can increase the urinary excretion of zinc. And lastly, high levels of iron may decrease zinc, and high levels of zinc may decrease copper. Again, this is usually seen with prolonged zinc doses of 150 to 450 milligrams per day. There are several COVID-19 guidelines published by national and international organizations. At the current time, zinc is not mentioned in the IDSA, NIH, WHO, SCCM, or NICE guidelines. This means that the guidelines don't comment favorably or unfavorably on zinc, they simply do not address zinc at all. In summary, I have presented that there is evidence in using zinc lozenges to treat the common cold. How this translates to COVID-19 is still unknown. Studies are ongoing, but the doses and salts are heterogeneous. The only available in vivo data is retrospective observational data that potentially show the benefit in non-ICU patients. Currently, no large treatment guidelines include zinc in their algorithms. Taking a step back, zinc is readily available. It has a relatively wide safety window with minimal adverse effects and drug interactions as long as the dose is below the toxic range. Therefore, administering zinc should have minimal negative effects, but the larger question is whether the administration of zinc will have any beneficial effects.